Good day everyone, I'm Scott, moderator for this webinar. On behalf of the organizer conference panel, I welcome everyone for today's webinar, Restraint and Seclusion, Navigating a Problematic CMS Standard. I would now like to introduce our presenter for today, Gail from Nash Healthcare Consulting.
Hi, and good morning or good afternoon. My name is Gail Nash, and I am a nurse consultant, and I'm also the president and CEO of Nash Healthcare Consulting. We provide consultations in various venues and hospitals and healthcare facilities for Joint Commission accreditation, for other accreditation organization facility or accreditation standards, and we also do a lot of work around the conditions of participation as well. So, all right, we will get started. The conditions of participation, there's a lot of them in the CMS State Operations Manual, and also, of course, those of you that are accredited with the accreditation organizations, there's a lot of deeming between Medicare and the AOs. And so I want to talk to you a little bit about why we're having this conversation today. First of all, we want to avoid deficiencies with any of your state surveyors. And for those of you that have experienced the citations under the state, of course, we always have to document and send in a plan of correction. And so this is an example of that. And we want to try to help in any way we can to prevent that from occurring. Now, this year in the executive briefings from the Joint Commission, which was last week, we learned that the patients' rights, restraint and seclusion is number 6 in the top ranking citations for CMS in 2022. Not surprising. The first one is under infection control, as you know. It's that too is a hot topic. But we're going to focus on number 6, which is the restraint and seclusion today. All right, let's talk a little bit about your policy. Now, you'll see with these slides, I've integrated policy kind of throughout all the slide presentations, because the policy really is your supporting document for the actions for which you are providing at the bedside. Once again, ordered by physician or LP, and you're going to hear this. You're going to hear me say this probably numerous times this morning because it is so important. Ordered, obtained prior to application or within a few minutes of emergency application. Defined who is authorized to initiate emergency restraints and seclusion. And so that needs to be in your policy. Generally, the physician, the LP, and nursing staff, of course, with requisite training and education. And including the orders. Here's the order piece, and I look for this in the EMR every time. The type, the duration, reason for use, time limited as applicable. Those are those violent, self-destructive, and signature date and time. Now with the EMR, the signature date and time now is a little easier. If you have a paper document, that's where it gets to be, again, a continued problem. Also, under the CMS as well and Joint Commission, if you're using paper documents, that document must be legible. And once again, we talked about no PRN orders, no stopping and restarting restraints or seclusion under the same order. I see this every so often too, is that we'll take the patient out of restraints. Patient has difficulty, an hour later, patient is placed back in restraints and no new order for that. Patient's rights. This is, like I said earlier, this is where the restraint and seclusion conditions of participation live, and all the tags. So patients have the right to be free from an unnecessary physical or mental abuse or corporal punishment. So restraints, here's a rule. Only use when necessary. So the surveyor is really going to look at the why behind any restraint that was applied. There's always a question too. Are we using restraints as coercion? In other words, to manage the behavior. Sometimes we see that in behavioral health institutions. We're using it for discipline. Sometimes too, we'll see that in behavior management programs. So we want to make sure that restraints are not part of that program, and that is distinctly identified there. Convenience or retaliation. The convenience factor, that is primarily to keep the patient in bed. Sometimes you'll see those kinds of things. It was more in earlier days where we saw some of that in long-term care. So of course, CMS has identified these as issues, and of course we'll certainly cite those for sure if they see evidence. Also, CMS guidelines apply to all hospital patients and even those in the behavioral health units. So make sure that you do some really good training and education on this one. All righty, we're going to go back to this plan of care again. I keep with restraints as we go through the ATAGs. There's a common theme. One of them is assessment, and it is reassessment, and it is policies and procedures, and it is appropriate orders, and then it is plan of care and education. So there's a theme that goes with each one of these ATAGs. And in this case, restraints must be used in accordance with written modification to the patient's plan of care. So in other words, I look at the plan of care and I see, now, if we put the patient in restraint after 2 days of being in the hospital, tell me why, and there must be some type of modification to the plan of care. In other words, we added the restraint. The restraint may be an intervention used for an underlying initial statement in the plan of care, or it can be a standalone interdisciplinary plan of care. Such as with the Cerner product, they use an IPOC, and so they will use evaluate and implement the plan of care individually, and both of them are fine. You must define the goal of the plan of care. In other words, the goal for restraints is we're going to remove this restraints within the defined time frame as the patient's assessment becomes consistent with removal. This is a little piece here about the impact of restraint. Joint Commission over the years talks about 40% of restraint-related deaths were caused by unintended asphyxiation. So we want to talk a little bit about that and make sure that that's being trained, and there's some education there as well. Also, restraints can be very physically and emotionally traumatizing to the staff involved. So sometimes we do trauma-informed care training for the team members, particularly in behavioral health and emergency departments. And then also it can impact the trust between the patient and the staff. So the patient then does not trust the staff member and afraid that this is going to happen again. So restraints have more of a tangible and intangible relationship. So the focus on reducing is significant there. All right. So once again, thank you for allowing me to provide this information. I know it's a lot of information, but that's all I have for this time. Please let me know once again if you have questions, and I'll be happy to help in any way we can.